I'm Susan French. I'm the Associate Vice President for Volunteer Services and Merchandising at MD Anderson Cancer Center. And truly, the conference each year is a highlight for me and for many others, an opportunity to learn from our experts about the latest advances in cancer treatment and to also connect with each other. So one of the really wonderful things we have today is that for the first time ever, we are going to live stream on MD Anderson's YouTube channel the medical panel this morning. So that will give an opportunity for survivors, community members, other healthcare professionals, and people throughout to be able to listen to our outstanding experts. So we're very proud to offer that as well. And now it is my real pleasure to welcome Dr. Alma Rodriguez. Dr. Rodriguez is a professor in the lymphoma myeloma department at MD Anderson Cancer Center and an expert in the treatment of patients with lymphoma. But in addition to her clinical responsibilities and of special interest to everyone who is joined here together today is her leadership as director for MD Anderson's Survivorship program. Under her leadership, our Survivorship program has become the foremost such program in the nation and a benchmark in the care and treatment of long-term cancer survivors. So it is truly my honor to welcome Dr. Alma Rodriguez.
Thank you, Susan, so much, and good morning, everyone. It is my privilege to mediate this opening session of presentations by our distinguished medical panel. But before I invite them up to our podium, a few instructions. If you have questions for our medical panel experts, we recommend that you write them down. You will notice that there are note cards in your table. Please write each question on a separate note card. After all of the presentations are done, if you would raise your hand, one of our volunteers will come by and pick up your cards. We will hold answering questions until all the panel presentations are completed. And now, I would like to invite our panel members to come up to the podium. Take a seat. Our first speaker this morning is Dr. Raymond Sawaya, who is the founding chairman of the Department of Neurosurgery at the University of Texas MD Anderson Cancer Center since the department was established in 1990. He is the past director of the Brain Tumor Center, also at MD Anderson, and as well as professor and chairman of the Department of Neurosurgery at Baylor College of Medicine from 2005 to 2014. He has received many awards, including the Joseph Evans Award in Neurosurgery at the University of Cincinnati, the Ann Brooks and Anthony Bullock Award, and the Charles Wilson Award from the National Brain Tumor Society. From our faculty at MD Anderson in 2016, he received the Charles A. Lemater Outstanding Achievement in Cancer, and that is the highest award bestowed by our own institution. Dr. Sawaya is a noted leader in the field of neurosurgery with particular expertise in improving the accessibility and treatment of primary as well as metastatic brain tumors, and is widely recognized for his efforts in improving safety of brain surgery. He will speak about the challenges as well as the innovations in the technology and research which are improving the treatment and outcomes of patients with brain tumors. Dr. Sawaya.
Well, thank you, Alma, and good morning. This introduction sounded too serious. I need to loosen you up a little bit. So first, to Susan, congratulations on 30 years of this activity and all the volunteers that are here and in the past who have helped. So what I thought I would do, we have obviously wonderful speakers. Dr. Litton will, I'm sure, tell you about clinical trials and some exciting new things. Dr. Futreal, or Andy, just to keep it casual here, is a top leader in genomics And genes and mutation is really what drive cancer. So we're going to hear wonderful things that are very informative. What I thought I would start off with, my field, as you heard, is brain tumors, but I want to use developing a comprehensive, multidisciplinary, integrated program. It happens to be for brain tumors and neurological tumors, but you will see many of the principles I will share with you can be and are applied to almost every other program at MD Anderson. So I hope it's informative. There will be specific patient cases that I will share with you. So moving forward, so again, the emphasis is beyond silos. Because we in the medical field, we tend to, hide in our own building, in our own area. I'm surgeon within surgery, medical oncologist in medical. That will not solve cancer. And I'm sure you all understand that. Those of you who had treatment or your family members, you've seen the number of specialists you have worked with. So beyond silos, how can we put together a multidisciplinary, truly integrated program? And that's really what I want to share with you. And I will, I'm not bragging, but I will say I've been at Anderson almost 30 years, 28 years to be precise, and I've helped build this program. So I really have been involved in it, and so I am sharing that experience with you. So, this, of course, thank you. This is a 30,000 feet view that shows you what happened over the last 40 years in relative survival rates for brain tumors. These are mostly primary brain tumors, tumors that originated in the brain. And what I want to share with you, especially the green graphs, is back in the mid-'70s when I was a resident in neurosurgery. 1 in 5 brain tumor patients lived 5 years. 1 in 5. Now, of course, many died within 1 year. What happened over 40 years, billions of dollars in care and research and advances and technology, and some of the stuff I will share with you this morning, is we've moved up to 1 in 3. So yes, the glass is half full. There's clear progress, 1 in 5 to 1 in 3. So 2 patients out of 5 now are able to live 5 years and past. But this is far from sufficient, right? We want cures. We want everybody to live past 5 years and past 10 and 50 and whatever. So this, I think, depicts the real life story. Tough problem. A lot of work has gone on. Progress is measurable and real, but we are not where we want to be. So I think this is a real story about my field, and I know it applies to many other cancers, pancreas, liver, and you name it. So how do you deal with that problem is what I want to share with you today. So I want to start with this one patient. His name is Anthony from Austin, Texas. This story dates back to 1994. And Anthony was 15 years of age. He had this tumor, and I don't need to point out to you the tumor. It's an egg-shaped, egg size in the center of his brain. His father is an anesthetist in Austin, so he's connected to the medical field. He found him a neurosurgeon who operated on him. And what the neurosurgeon did, and I'm sorry I can point only on one side, I'll go back. What the neurosurgeon did, he went back here, which is a standard approach, got a biopsy of this tumor. During surgery on frozen section, he was told it's malignant, and he couldn't get the tumor out. So he closed went back out, told the parents, father and mother, that this is a malignant tumor, it's inoperable, and he said, don't let anybody touch your child. Now, I use that example because it's so real and so paralyzing. And so he came to Anderson, received excellent oncology care, radiation, chemo, but this tumor kept growing. This egg shape get bigger. This kid, his face was, I'll show you his picture, became this big from the cortisone steroids he was given, and he couldn't see living this way. And his parent refused a neurosurgical consult because of what that surgeon told them. And you don't blame them, but why do I use this case is because it really does take a center of excellence, a place where problems of this nature are seen on a regular basis, even if it may be a rare problem, are seen on a regular basis. There's experience, there's expertise, there is a way of thinking that doesn't give up, that always looks for the solution. And so I looked at this. Finally, Anthony, age 15, convinced his parents that he cannot live this way, and they allowed him to come. It happened, they saw me at the time. And so what you see, and again, from a neurosurgical standpoint, this would not be the approach because it's too narrow. We have a way of coming to it from above. And now I will not spend too much time. There's technology, navigation, GPS, indicating to me how to get in. Got in, beautiful circumscribed tumor, incredible anatomy, and I don't want to belabor the point. And here's the tumor before surgery, here's the tumor after surgery, completely gone. And here's Anthony. Anthony came back 6 months later, that picture on your right, I didn't recognize him. Off steroids, his hair grew up, his face thinned. Now, the reason I can share that story with you is his neighbor in Austin is a journalist that worked for the Austin Statesman, their local journal, like our Houston Chronicle here. And when he heard his story, he was moved and he wrote up his story. So his picture, the one on the right, is on the cover of their local news. So it's public knowledge. He's alive today, free of cancer, free of disease. So, yeah. So that's the point, is these are tough problems. And they have to be evaluated, assessed by centers of excellence that have seen, that have dealt, that have the big picture, and that will not back away from tough problems because all life is filled with tough problems. So moving forward, and I told you I want to tell you about the building of an integrated program. What are the principles? What are these foundations, these pillars on which you can build a structure that will be not only strong but will last? And so there are 5 issues here, and again, it applies to practically all cancer programs in our institution. Patient volume, I will tell you what I mean by this. Technical challenges, you just saw an example, a true technical challenge, and there are many, many others. Issues of curability, I showed you in my first slide. Most patients are not being cured in my specialty, and so what a challenge is this? So what a terrible problem, but what an opportunity it is to move forward. Multidisciplinary organization. There is no one specialist that can solve these problems. It's only when we all come together, each of us in our specialty, bring the top, the best that we can bring, and then together we're going to make progress, as I believe we have. And the last issue, I don't need to expand that for you. Cancer, per se, is paralyzing when you hear it. Brain tumors is a terrible, scary thing to hear being told you have one. And so there is a real psychosocial dimension that affects us, affects our family, our caregivers, our friends, our kids. And so how do you deal with that? And what's our role on the medical, scientific side to help deal with that? So again, these really do apply to practically every aspect of what we do at MD Anderson. So this is from the American Cancer Society. They publish every year the cancers. And yes, Jennifer is a breast cancer specialist, and you could see in women it's a very, very prevalent, 230,000 new cases per year. This is in 2014, and numbers are about the same now. So they talk about the big four: prostate and breast, lung and colon cancers. And they are big four because numbers speak loudly. And for me, working in the brain tumor field, I look at this slide and the top 10 cancers in men and women, I don't see the brain. So when I speak about a neuro-oncology program, I emphasize that there are huge numbers that don't show up here and require a truly expert multidisciplinary groupings. Here are just examples of primary brain tumors. Primary brain tumors, 40,000. Metastatic brain tumor, those are cancers, whether breast or lung or melanoma, skin cancer that travels to the brain. Well, who's going to take care of these patients? You need a neurologically trained expert on the medical and surgical and radiation side. 100,000 patients per year. Spine metastasis, you will know where the spine is. And when you have a metastasis that destroys the bone of the spine, well, guess what? The spinal cord gets compressed, and the patient may become paralyzed or lose bladder control, sexual function, and you name it. Serious problems. Who's going to take care of these patients? Neurologically trained doctors who understand these problems and have the tools and the techniques to help them. So I show this slide to say the numbers are staggering, but they don't show up on the top statistics. And that's why, again, we felt when we started our program at MD Anderson in 1990, was that we had to bring all these experts to work together to help manage problems that on the outside may not be readily managed, and you saw Anthony's example. And so look what happened to our program from 1992, just steady growth. I stopped counting because the need is out there. You bring the expertise, you bring the effectiveness, then the need is there, and patients who need those services, if they are lucky enough to find the place, they will come and they will have the care provided. The technical challenges, again, I think you saw an example with Anthony. That was not an easy surgery, so you need anatomic skills. Brain is a complicated organ and a lot of important function there. Surgical skills, technologic skills, the tools that we use now in the operating room or outside of the operating room, even in research, are incredible. The molecular biologic skills, you can't anymore say, take 2 aspirins and call me tomorrow. That won't do it. It's much, much more complicated than this. We're using viruses to kill brain cancer cells. And of course, interpersonal skills, we should never forget that is needed. So, the brain is like in space. You can get coordinates and use a GPS, and you can, like Anthony's tumor, pinpoint exactly where the tumor is and not get lost, because nobody has X-ray vision. And here's comparison between how to go to the moon and how to go deep in the brain. Same principle, X, Y, and Z. Coordinate, you find a spot, you go after it with precision. And here's a navigation system. We started using this one I used on Anthony in 1994. It was a beta test site. We got it from Toronto. And since then, of course, it moved into much more sophisticated LED and whatever. But it's a GPS, like in your car, but precisely leading you in the brain. Look what happened to, in 1994, I probably used it, 12 times. Now we're using this GPS over 700 times per year. So it becomes a second nature because, again, we don't have X-ray vision. We need that technology. It's not a gimmick. It's a real advance that helps us do more precise surgery and safer surgery. Ultimately, we're able to convince our administrator to invest $9 million in this so-called brain suite, which has an MRI 1.5 Tesla, that's excellent magnet, which is what we use to scan our patient on a regular basis. So we can do it in the operating room. And a quick example of this physician came from another state, had this big tumor. I operated on him, and I have a lot of experience operating on these patients. I thought I had it all out. And so part of the study, and we did that prospectively, was to, when we think we're done, we would stop, tell the technician in the operating room that we're ready to image the patient, and we had to fill a form that says how much of the tumor we thought we removed. I thought I got 100% of it out. Well, guess what? I left 20%, here's volumetric measurement, 81% of it was removed. I left 19%. With a tumor like this, 19% is not going to work. These are very resistant tumors. You have to get to nearly 100% removal of the enhancing mass. And so in the operating room, we had this feedback, we had this information. We didn't send the patient to the floor, and the next day did the scan, which the way we used to do it. And so I was able to complete the job right there, right then. And so we, of course, published many papers on that and demonstrated the effectiveness. Issues of curability, you've already heard my comment on this. Most malignant brain tumors, on an average, do not survive 15 months. Then this is totally unacceptable. So just think of the incredible potential for therapeutic innovations, and you will hear some of that applied to other cancers. Of course, we are also working to apply it for brain tumors. It does take a village. We were fortunate to consolidate our research program for neurosurgery, neuro-oncology, neuropathology, and radiation oncology. Again, look at the multidisciplinary coming together for research. It's not for patient care, it's for research. We occupy the entire 5th floor of the George Mitchell building, which is a state-of-the-art genetic building with an incredible vivarium where animals are cared for because we need animals for research. And so we have 100 individuals who are working. Some are technicians, some are students, some are postdoctoral fellows, and of course several of them are physicians or Ph.D. scientists. So that's what it takes. This is the largest group in the country working on brain tumors to make advances. Incredible science fiction type work has taken place. Now these are common, and the geneticists among us use these animals, engineered animals, on a daily basis. But back then, when this study was done, Eric Holland was one of my faculty, a very, very prominent, he's in Seattle now, very prominent physician, scientist, neurosurgeon, showed for the first time that you can, in specific brain cells, this is the science fiction part of it, specific cells in the brain of this mouse introduce two bad actors, RAS, an oncogene, and AKT, two bad molecules that make cancer really bad and resistant to therapy and suppress immunotherapy or the ability of the immune system. And so he demonstrated that if you combine those two, you create this most horrible tumor called glioblastoma. John McCain died of just a month ago. So now we know what are the mutations that are occurring, but we don't know why. We don't know why they're occurring in patients. So a lot of research is going on that, and I think Dr. Futreal is in the leading edge of that type of research. And so, again, I move on. Innovative clinical trials, and you're going to hear of some of those trials in a minute. But this is what is called today precision medicine. What do they mean by precision medicine? Well, the basic principle is you want to know what are the molecular and genetics mutations or aberration that are occurring in any given cancer in one individual person. And then you have to identify those targets, have the drugs or combination of drugs that go after that target, see the response. Patients, some will respond, some are cured, some don't respond at all. Why? Why this difference? Well, this is where the database comes in, and the database is going to sort through artificial intelligence or big data or whatever term is being used now, and based on that, it goes back to inform what happened to the patient. So that is precision medicine. Now, it's easier said than done. Most patients don't have a recognizable mutation, or they have mutation that we don't have drugs against. So those are really the big challenges that we are facing and we're trying to solve. So we felt that to help our team move forward and advance, we needed to build infrastructure that are needed by each program. Those are 3 examples. Tissue bank. When we take a tumor out of a patient, this is gold. This is very valuable information that, again, for precision medicine, will inform us what's specific, what's real unique about this tumor in this individual. Because ultimately, that's the only way we're going to move forward. You know, if you take a shotgun and kill everyone, it's not going to work. You want to be much more precise, much more targeted. So tissue bank, the database I've alluded to earlier, and the animal core. Those 3, they cost money to have these available to our physician and scientists to help them do. And so they used our tissue bank at NIH when they did the TCG, the Atlas of brain tumor cancer. They created an atlas of all the mutation in these tumors by sequencing 200-some tumors. Well, half of these tumors came from our tissue bank because we invested in it, and we had excellent tissue that we saved and we gave to NIH when they run that. So again, value of investing in infrastructure. Database, again, Dr. Suki happens to be a top leader. She's an epidemiologist, and look at the number of patients that we have now in our database. Gold mine that you can go back and mine and get data on. And I'll skip that. And animal core, I've already showed you how important animals are in doing research, and here's a model that we have used. And I demanded a yearly report because we pay for technicians, and that costs us money. I want to know, are we using our money wisely? Look in yellow here, in 1 year, 1,500 animals were tested in our core facility to help 10 and 12 investigators test new drugs, new viruses, and whatever. So again, this helps other labs not to have to reinvent the wheel, learn the techniques, and they may not do the proper animal experimentation. So having that for them is very helpful. Multidisciplinary organization, that is absolutely a key. I said earlier, not one specialist. Surgery is not going to solve brain cancer. It's going to help, but not solve. Medical intervention, drugs, is not going to solve brain tumors. It's going to help. Radiation, and you name it. So it's by bringing everybody together, Unfortunately, as I said, in medical schools, we are taught to live in silos, radiologist in radiology, medical doctor in medicine, surgeon, pathologist. That vertical layers is not what is going to solve the problem. It's the horizontal layer. And really, MD Anderson was the first place, and is recognized, the first place for multidisciplinary delivery of care. But it's not enough to have multidisciplinary delivery of care. You want a multidisciplinary integration of a program that includes other specialists, including research, because the only way to advance, integrate what we learn in research, bring it to the clinic. And here, this is our program, and I believe it's one of the best integrated programs at MD Anderson. And we, of course, have meetings like this, share ideas, share thoughts. And let me close, and I'm sure I've taken much more time than I was assigned. Let me close by, emphasizing the need for compassionate care. Again, I think, having been at MD Anderson almost 30 years, I know it's in our DNA. I know it's in our genes. It's in our volunteers' genes. It's the way we live, the way we breathe. And don't take it from me. Many of you have walked the halls and have dealt there. There's an incredible level of empathy and compassion, and it is needed, and it's a must. And so the patient is a whole. You are not, a brain or a breast or a colon. You are a human being. And so what affects this brain or this colon or this breast, guess what? It affects all of you. It affects all of your family and all of your caregivers and all of your friends. And so it really is an earthquake. And so look at the patient as a whole, provide compassionate care, meaning listen to the patient, hear what they're saying, understand what they're going through. Case management is very important. There are things, as physician, I cannot handle. Patient has a paralysis, we did surgery, they're doing fine with surgery, they're from out of town. What do? I send them to the hotel? Well, they can't walk, they can't go to the bathroom. We need case management, we need social workers, we need support staff who specialize in helping these patients, depending on their situation, deal with their problems. So, complex. Rehabilitation issues, patients will have problems, or may come with problems that we have to deal with, and support group is essential. And so, here's Michael, 24 years of age, came, as you will see on one slide, from Oklahoma. His surgeon did a biopsy, and you may not see, but they did a biopsy up there, told him it's a malignant brain tumors, you have 6 months to live. 24 years of age, just think of your son. My son is older than 24. So 24 years of age, you're told you have 6 months to live. Who is God among us? As far as I know, nobody is God among us. We don't know. We do our best. Sometimes we fail, but sometimes we succeed. So he came to me. Obviously, he was down. He was depressed. Could see it in his eyes. But he wanted to fight. And he said, what do I do? So I looked at his scan, of course, from a neurosurgical standpoint, and I said, there is no reason why I could not take this ugly-looking tumor out. And again, I don't need to point to you, all the white stuff is ugly tumor that goes all the way down to the corpus callosum, critical part of the brain. So without belaboring the point, I used the, magic navigation system and other ultrasound and other tools, got all the way down to the bottom of it, got a scan after surgery, got all the visible tumor out. Now, we all understand there are microscopic cells left behind that are responsible for these tumors coming back. So, as I said, surgery alone is not going to cure this patient. But without this kind of surgery, this patient has no chance of living. Certainly no chance of living 5 years. So he did extremely well. I was so happy. I sent him for a picture. I wanted to document how well he did. And so he went to the photographer at MD Anderson. I wasn't with him. And here's Michael. Of course, I have his permission to show that picture. So Michael, 1998, right? Look at his sense of humor. He's telling you, hey, I just had brain surgery, and guess what? I'm not paralyzed. Because that was one of the risks of the surgery, was paralysis. And, you know, he has staples still on, so it's very fresh. Look at his eyes. This is somebody, not only that has a sense of humor, but that is wanting to face life and to deal with the problem with confidence. This is what an integrated center of excellence can provide patients, is giving them confidence, giving them hope, because without that, well, guess what? It's 2 thumbs down. And so this is 1998. He sends me a Christmas picture in 2006. Michael is alive today. In fact, 2 years ago, they got a scare. His wife had headaches, and they did an MRI. They found something, and right away got in the car, drove down from Oklahoma to see me. It was a small, benign cyst, no concern, nothing to do about it. They went back home. So I know he's doing well, and his family is doing well. So let me close by saying that we are all technicians. This is a technical world. Technology surrounds us. Can't breathe without technology. So we're all technicians. But do we want to function as just technician that just presses button? Or do we want to use this technologic expertise and knowledge integrated with our other specialists to deliver a comprehensive disease management? This is where technology makes a difference and can add to our human interactions. And so the summary of our goals, and again, remember, this is not limited to the brain tumor program. This can be applied to every other program at MD Anderson, is patients' interest gets first priority. That's why we exist. We're not here to only cure rats and mice. We're here to help humans deal with cancer. Technical and biologic skills are maintained high. This is really getting very complicated, and we have to be able to understand and master those skills. Integrated teamwork is a necessity. In fact, without it, there's no future. And clearly, research will provide the ultimate cure, because many patients today are not being cured. So put all that together, and you have a winning solution. So some of you know this sculpture from the art district in Houston. I use it to say I apologize. I played my own music here, but it's the music that I understand best, and I thought I'll share with you that experience. Thank you very much.
Thank you, Dr. Sawaya, for this very inspirational and actually comprehensive perspective of really how all of our cancers, all our disease-specific centers at MD Anderson operate, that is in a comprehensive and multidisciplinary mode. Our next speaker is Dr. Jennifer Keating-Litton. She's an associate professor in the Department of Breast Medical Oncology and Clinical Cancer Genetics, and she holds an additional faculty position at the Graduate School of Biomedical Sciences as well. She is the chief of the section of clinical research and drug development in the Department of Breast Medical Oncology. Her research interests include the treatment of young breast cancer patients, including those who are pregnant during the onset of their malignancy, treatment-related infertility, hereditary cancer syndromes, immunotherapy, and triple-negative breast cancer. She is the principal investigator for multiple clinical trials, and she will address with us how treatment today for breast cancer patients is being tailored to address the biological and genetic characteristics of each of their respective disease. So, Dr. Litton.
So thank you so much for inviting me to speak today, and thank you all for being here. This is, such a thrill for us to come up and be able, to talk to you about what we're doing. Now, I've been given 10 minutes to discuss everything going on in breast cancer research, so I think that we can understand that I probably won't get to that. I did want to just say one thing in response to Dr. Sawaya's amazing presentation. When I first got interested in cancer research, it was right out of college. I went to Dana-Farber, and I was a research coordinator before medical school for breast cancer trials. And at that time, in the early 90s, the clinical trials were, well, we have 5 different chemos. How many different ways can we do trials to put those chemos together? And that was really the extent that was going on at that time in breast cancer research. And now the development and the rate is so intense that now half of our job is trying to figure out innovative clinical trials, and that clinical trials shouldn't just be about the drug we're giving. It shouldn't be the silo. It's pulling in the multidisciplinary. It's learning as much as we can. Dr. Futreal and I have multiple studies together where we're collaborating on that. And not even just in the breast cancer world, because these drugs are being used. Maybe my friends in colon cancer have had more experience with this drug, and we really spend a lot more time now in 2018 talking to my friends in the other tumor types, because we're finding a lot of similarities as well. So with that being said, in 10 minutes, breast cancer 2018, I work with really every single drug company because that is my job. I've refused every honorarium from every drug company since I became a doctor. So my objectives today, I wanted to talk about just some of the bigger changes in breast cancer, specifically staging. And I picked out a trial for each of the different subtypes, some that MD Anderson led or involved, and some we didn't, but I think affect all of us in this room who are affected by breast cancer. So first of all, one of the things I want to notice is that if you are a breast cancer survivor or you know a breast cancer survivor, there may be some confusion because the staging system has completely changed 4 months ago. So someone who thought they were a stage 3 is now a stage 1, and how did that happen? And I'm very confused. Well, you are not alone. All of us are very confused, and when you see records, we might say, well, in 2017, stage 3, but now stage 1. And so there are changes, so if you're concerned about that in your record or your loved one's record, that's a good conversation for you to have with your caregiver. So this past year, basically, staging started quite a while ago, back in the 70s, to try to figure out how can we give people an idea of what their chance of recurrence is, what their patterns of their disease. And it's just been updated along the way. And we've been rolling with the AJCC 7th edition for a long time now. Dr. Gabriel Hordabagi and Mariana Chavez-McGregor from MD Anderson really led in this effort to change that it can't just be about the size of the tumors. We know so much about biology, and we have to integrate the biology of the tumor when we're giving people an idea of their prognosis. So in the 7th edition, all we looked at was really the stage. How big was the tumor? Were there lymph nodes involved? Was there disease outside of the breast and the regional lymph nodes? And we looked at it both before we gave treatment, that's the clinical stage, and then after. And that is the extent that we have been working on. But we really recognized that there were limitations to this, and we really needed to make stage meaningful for patients and to help them with their prognosis. And so in addition to the anatomic stage group, so how big the tumor is and the size of the lymph nodes, we really needed to look about, was the estrogen receptor involved? Was HER2 overexpressed? And now with multiple gene panels, how can we put that into perspective? So the 8th edition really looked at incorporating this, and you can see a lot of patients who thought that they were much more on the aggressive stage really have been downstaged by putting together some of the biology of their particular tumor. And so this is just for you to see that really we take into account a lot more in the 8th edition that has ever been done. Moving on to estrogen receptor positive breast cancer, I really just picked some of the highlighted studies from this year, and the one I really wanted to highlight was the TAILOR-X trial, because just as important it is to push forward and add more therapies and figure out synergy, we can't forget that we need to see where we can pull back, where we can get the same results with less therapy and less side effects as you go on decade and decade into your survivorship. So the TAILOR-X really looked at women who had node negative but ER positive disease. And so what was done was women who had ER positive node negative disease underwent this test on their tumor once it's been removed to look at 21 genes and to give us an idea of how important chemotherapy would be or not in addition to the anti-estrogen therapy. Now, this test has always been very helpful even long before this study because we knew that in the early stage, in the low risk, that chemo didn't add benefit. And in the high risk, yes, chemo absolutely saved lives and had benefit. But what did we do with that group in the middle where we really didn't have that information? And I will tell you, a lot of patients end up in that middle. So what did we do? We randomized those patients to chemotherapy or no chemotherapy, but everyone got anti-estrogen therapy. We did adjust the ranges that patients were considered intermediate because we wanted to make sure that we were giving people who needed chemo. And what did we see? Those patients in the intermediate. You see those two lines? You probably don't see two lines because they're right on top of each other, right? There was no difference as far as the women in the intermediate range who got chemotherapy or not. So in other words, they got the same benefit from anti-estrogen therapy alone as they did to the combination. So we've now identified a larger group of women that can avoid chemotherapy but still get the same good benefit from really maximizing their anti-estrogen therapy. And so I think this is so important to see where we can keep our outcomes and prognosis for you without using chemo. Now, I love chemo, I use it when I need to, but what if I don't need to use it? I don't want to use it. So here are the summary, that endocrine therapy alone was non-inferior to chemotherapy plus endocrine therapy, and that there was one thing they started, and this is a problem with us as investigators, we start to go and piecemeal out data. Was there some women, the very young women under 50, that may have benefit? And there were some groups in the higher intermediate range if you were under 50, and we still have that conversation about chemotherapy in that group. For HER2 positive breast cancer, again on that same theme, I thought this was really interesting, the Persephone trial. We routinely give anti-HER2 therapy for a year after we complete chemotherapy. Now, we've even expanded that with other drugs for 1 year, 2 years, which we can certainly do, especially if someone didn't have as good a response to chemotherapy as we would want to do. But I highlight this study because this study was done with governmental funding and asks a question, can we do less? and get the same results. And so the Persephone study looked at giving 6 months versus 12 months and looked at outcomes such as toxicity to the heart and things, side effects of our medications. And they again didn't see a significant difference in those patients who received 12 months versus 6 months. Now we have to put that into context of multiple studies because several other studies did show the benefit of 12 months versus 6 months. We've also changed how we give anti-HER2 therapy from when this trial was started. And I think that putting this into context, we tend to decide that if a patient didn't have a great response to chemotherapy, we might push further on the anti-HER2 therapy and go an extra step or two. And for me, for some patients who are having side effects, who are having toxicity to their heart, if they're doing well, for those patients that need to stop at 6 months, I feel a little more confident to do that now. Triple-negative breast cancer. I wanted to mention two drugs in this situation. I'm not even going to enter into immunotherapy, though I suspect that after October of this year, we're going to hear finally some first good results of immunotherapy in triple-negative breast cancer. But we are seeing some new drugs designed specifically for patients. And sacituzumab is one of them. It is one of the antibody drug conjugates, and I think this is exciting. These are drugs that are vehicles that find the tumor cell, get attached to the tumor cell, get eaten into the tumor cell, where they then deliver their payload of chemotherapy directly to the cancer cells with the idea that we're targeting the cancer cells and sparing a lot of the other tissue and side effects that patients might experience. And so this is how this drug looks, and I just described it. And this single-arm open-label study looked at patients with metastatic triple-negative breast cancer, which still remains one of our toughest breast cancers to treat, and gave them this chemotherapy. And what we're seeing is responses, complete responses and partial responses that are still ongoing. And because of this response, this trial is now going forward into multi-center trials, and we'll be moving it forward into the early breast cancer setting for patients with triple-negative breast cancer who have resistant disease. And to end, I want to talk about a new class of drugs that has been in the news a lot, but have really, I think, have a new role in breast cancer. Our ovarian cancer friends have been using them for a lot longer than us, but we really, I think, now have an established role in breast cancer. So there's a lot of ways that we repair our DNA. One of the things that we know is that patients who have a BRCA mutation, they already can't repair one of their ways of repairing their DNA. But one of the ways it gets around that is by repairing it down a different pathway that uses PARP. So what if you can't repair your tumor DNA one way because the BRCA is shut off, and we shut off the escape pod on the other side, and those tumor cells die? So the Olympiad trial looked at patients with HER2 normal metastatic breast cancer patients who had a BRCA mutation. They had less than 2 prior chemotherapy lines. They had standard chemotherapy, and they were randomized 2-to-1 to olaparib twice a day versus chemotherapy of the physician's choice, with the idea to treat to progression. And what we see is an improvement in the progression-free survival. Now, this study was not done to look at overall survival, and they're following that. But what we can see when they look at each group, was it BRCA1, was it BRCA2, was it triple negative, that really every group on the left benefited from the PARP inhibitor when compared to the standard chemotherapy. Now, the Embraca trial, also an international trial led by MD Anderson, looked at a single talazoparib, 1 milligram daily versus physician's choice of chemotherapy, very similar. And Dr. Sawaya, you'll be happy to note that we did allow patients with brain metastases, and it was actually a large proportion of patients in this trial, and we made a point to do that. The progression-free survival was significantly improved, also compared from 5.6 months to 8.6 months. But what was exciting about that was that this trial is also actually powered to look at survival, and we are seeing early trends in survival and durability. But what the Embraca trial and the Olympiad trial showed that this class of drugs, an oral drug, when we gave it to metastatic cancer patients, that people felt better. They became more active versus chemotherapy, where they did show some activity decreasing. So we've made them have a better outcome and, more importantly, had them feel better. So these drugs also, we're looking at how to make them better, last longer, and include patients that don't have a BRCA mutation, but all other types of breast cancer. It's already moved into the preoperative setting as well, where we're looking at trying to use it instead of chemotherapy in early breast cancer. Now, there's multiple future directions. Immunotherapy is a whole other discussion that would go on for an hour, the PARP combinations. And we are swiftly improving how we give anti-estrogen therapy with combinations, both in the metastatic setting as well as early breast cancer. So I wanted to thank all of the patients who participated in these and really every trial. And to my friends, Dr. Mittendorf and Dr. Chavez-McGregor, who did help and provide some of the slides for our work here today. Thank you.
Thank you so much, Dr. Litton. Her presentation highlights how, although we think we know and have made great strides in improving outcomes for many patients, we still have a ways to go, and we're continuing the journey of discovery. And speaking of the journey of discovery, our third panel presenter is Dr. Andy Futreal. He's a professor and chair of the Department of Genomic Medicine at MD Anderson, and he's noted for several major scientific discoveries. Key to these discoveries was the identification of the BRCA and BRCA2 breast and ovarian cancer susceptibility genes, and you heard Dr. Litton mention that in her presentation. That is leading to significant changes in how we treat patients. He was also the team lead in a pioneering project in a large-scale systematic cancer genomics study that led to the identification of the BRAF mutations in melanoma, ERB2 mutations in non-small cell lung cancer, and multiple other new cancer genes that have been identified in renal cell carcinoma. In 1995, he received the National Institutes of Health Public Service Award for the discovery of the BRCA1 gene and its significance in hereditary risk for ovarian and breast cancer. In 2015, he was also the recipient of the Jack and Beverly Randall Prize for Excellence in Cancer Research. So he is a luminary in the field of cancer genetics. His goal is to apply his knowledge in cancer genomics to improve both short-term and long-term patient outcomes, extending to survivorship. And he will share with us today how today's scientific research efforts at MD Anderson are changing cancer treatments today and how we hope to change them in the future. So Dr. Futreal.
Thanks very much for the opportunity and indeed the privilege and the honor of being able to not only sit on this panel, but be in this room with you this morning and shift gears a little bit to give you a sense of what we're trying to do on the research side to help drive some of the advances you've heard about. And just as a personal note, to hear Jen talk about the impact of BRCA1 and BRCA mutations 23 years after their identification is personally gratifying, but I think shows you the trajectory that we hope to continually shrink, and that's what I'm kind of give you a sense of this morning, is how do you move faster from that initial identification of an event or a molecular aberration or some facet of a cancer sort of phenotype, if you will, and move that into something that actually has real impact in patients. And that's sort of why we do what we do. I'm going to concentrate this morning just to give you a sense of a really focused research effort that one of the hats I wear at MD Anderson is to co-lead the Moonshots program, or at least try to help steer it a little bit. And the Moonshots program was conceived probably about 6 years ago now when Dr. DePino came, and it was centered around a relatively simple idea. And from the genomic space, which you've heard a bit about, technology that Ray talked about, this knowledge about the intricacies of cancer at the deep biological level, we're all sort of coming together in such a way that the question was asked, if you brought all that together in a very team-oriented way, again, to sort of reemphasize the points that have been made this morning, this is a team sport if there ever was one. If you brought that together and supplied it with ample funding, technology base of activity that didn't require every investigator to now reinvent that wheel every time they wanted to do some work, could you change the trajectory of how we did research into, again, decreasing the cycle time from research to impact in patients? And this was sort of the genesis of this moonshot effort, and it was very much about this idea of interdisciplinary teams. I mean, you've heard Ray and Jen talk about it takes multidisciplinary efforts to treat cancer. Cancer is a complicated disease, and the notion that on a research side we can do it in silos is absurd. It's an incredibly complicated problem, and we need to bring together teams of people to do research on cancer in exactly the same fashion that you have teams of people to treat cancer. And that notion has virtually escaped the academic medical community since it began. I mean, we're organized, we're rewarded around silos of activity, and we have to break that cycle in such that actually the problem is actually to solve the problem, not to pad CVs, to be perfectly candid. That's my high horse soapbox stuff. I'll stop now and I'll move on to the other stuff, but there we are. So very much about interdisciplinary teams and really thinking about the scope of the problem, from prevention, detection, treatment, and really thinking about how we can stage ourselves. And I'll come on to some personal thoughts at the end about thinking about the longer course and trajectory into the survivorship space. The key principles there is you have to have dedicated money, dedicated time, and dedicated infrastructure. This can't be a part-time job. And so one of the things we decided when we tried to set up this program was really think about adequate funding, and that has been made possible largely from the Moonshot efforts through incredibly generous philanthropic support. The lion's share of what I'll show you briefly here is all driven from philanthropy. So that is an incredible testament to the vibrancy and the passion in the community about trying to make a difference and helping us to make a difference. So again, sort of the key things we measure are it has to be a team-based approach. There have to be, by definition, interdepartmental collaborations. It can't be one department doing everything. Data. We have to quit hoarding data. Again, we sort of get rewarded as researchers for keeping everything close to our chest and publishing it in smaller and smaller increments. That has to change. And there has to be a sense that we have to be able to take risks. And again, one of the reasons for funding things in this fashion from philanthropy is you can fund things that would be very difficult to get funding from the traditional sort of NIH grants or NCI grants because it's too risky. And that, by definition, is a much more conservative organism, if you will, when it comes to funding. The other thing we changed, which again was a moving away from a traditional sort of academic medical sort of environment, was it's very much milestone and goal driven. So if you say you're going to do X, Y, and Z in year one, at the end of year one, you're going to get asked, did you do X, did you do Y, did you do Z? And that's how we measure things. And that's much different than sort of a traditional sort of research grant where you write a grant for work you've sort of already done a little bit and you show preliminary data to get some money to do the stuff you're thinking about doing for the next few years. Lather, rinse, repeat. That's hugely productive and incredibly valuable and the life's blood of basic science. But is it the best way to move things forward in the clinical translational space? And so the project was sort of started, again, sort of going on for 6 years ago with the central tenets. And when we started with, not trying to do every cancer type, But how do you focus? And the first wave is shown in the 2013, the inaugural programs, if you will. And this was put together with proposals and a group of about 13 or 14, I think, internationally recognized investigators and clinical leaders to say which ones sort of fit the bill in 2013 as that most shovel-ready, if you will, places where if we just brought the right teams of people together, could we have a line of sight on generating impact in the clinic in the 5 to 10 year sort of time scale, which was sort of the goal. And you can see them listed there. Again, it hits some of the big four, as Ray pointed out. We have leukemia, actually 2 kinds of leukemia because it's such a strong expertise at the institution, prostate, melanoma, lung. And at that point, we put breast and ovarian cancer together as a women's cancer moonshot, primarily through this axis of BRCA1 and BRCA2 mutations that you heard about from Jen. That's proved a ramp-up period. How do you get these things started? How do you build that infrastructure? How do you bring those teams of people together? We're not born thinking that way. That had to be built, and there was a bit of a run-in period, which had some hiccups and speed bumps and other things in the road, but we got there eventually, such that around 2015, we decided, well, it looks like this is something that has legs. How do we begin to sort of think about a next wave? And the next wave is shown in 2015. And what I want to point out about that, other than sort of you seeing sort of the tumor types and the tumor areas there, is the second 2 bullet points there, glioblastoma and pancreatic cancer. Unfortunately, as Ray and I were talking about before we started, these are 2 incredibly difficult diseases. But what we thought about was, can you take the same idea of team science, good support, platform-based from a technology standpoint, and apply the same ideas to cancers which may have really things ready to go the clinical translational space, and actually apply that to cancers where it's a much more intractable problem at this point in time. So can you use the same principles to drive more into the more black box tumors where we don't know as much as we do, let's say, as we do about melanoma? Can we use that same team-based approach to sort of drive research into those 2 areas? So this was a bit of a shift in emphasis, but I think it's the right one, because eventually what you want to do is establish a culture all the way across the institution. So it doesn't matter whether you call it a moonshot or not. The principles apply of team-based research, really tightly integrated with the translational clinical space to actually get the work done and make this a sort of an institution-wide culture shift. And I think we're really far along the trajectory of getting that done now. One of the key factors, and probably the differentiating factor of this effort, was thinking about not only the teams of people, the clinicians, the physicians, scientists, the basic science researchers, but giving them tools, empowering them in such a way that they don't have to go recreate that stack of activity every single time they have an idea. And this was unique, and every time we have the scientific advisory board, which we bring experts in from all over the country to review the program, the one thing they always comment on is they wish they had this at their institutions. And this is this idea of platforms. This is saying, let's centralize the technology such that everyone has access to it, and they spend their time thinking about the important problems rather than trying to build, a mousetrap. Let's centralize the mousetrap factory. That's probably a horrible analogy, but there we go. And you can see the breadth of these platforms actually ranges in a pretty staggering wide variety. And the first one is cancer prevention and control. And so this says if you have good ideas in the cancer prevention and control space from a research perspective, you still need to get that out there. And very few academic researchers are trained to think about how do you get it out in a public way and make it effective. This is a platform aimed at doing that activity, thinking about everything from tanning bed legislation to tobacco control, et cetera. You can see the other ones, genomics, immunoprofiling, proteomics. The Apollo platform is a platform that is purpose-built to think about how do you collect samples over time in patients so we understand the disease as it evolves under treatment and over time, rather than taking a snapshot and trying to understand a very complicated bit of clinical biology down the stream. We have 3 drug development sort of units within here, the IACS, Orbit, and the ACT, which are involved in small molecules, antibodies, and cell-based therapies inside the shop. And so what I tell people when they come interview, I said, it is literally possible in a metaphorical sense. You can have an observation in the morning made on the genomics platform, have a conversation about 10 o'clock with one of the sort of the experts in drug development and have a molecule in the clinic by the afternoon, all within the same, thank you so much, all within the same, under the same roof. And that's a fairly unique set of activities at an institution. I can think of maybe one other place on the globe at the moment that can pull that one off, and I think we do it much better than they do. Bragging a little bit, but but that's the ability to integrate all the way from basic science to translation to real expertise in thinking about drug development either inside the house or outside the house, and have an armamentarium of incredibly talented clinicians to implement that in terms of cutting-edge clinical trials, all within the same roof in the same institution, integrated in a very team-oriented environment is hugely powerful and unique. And I think it can't be underestimated, the power that that brings. I wanted to give you just a few recent highlights, and then I'll give you a few thoughts on sort of more what we do in my laboratory and where I think we need to go. A few recent highlights, again, largely culled from 2018, I think. The first one was, and these are things that Moonshots either contributed directly to or helped drive from funding standpoint, the whole area of cell-based therapies. So Dr. Neelapu there, and the first author on this New England Journal paper, this is the CD19 CAR in diffuse large B-cell lymphoma, which has been an absolute game changer in treatment and in highly refractory disease in that patient population, led by an MD Anderson investigator, again, sort of leveraging the power of the institution and the Moonshots as well. This is a really interesting example, again, sort of helped funded by the Moonshots in lung cancer, of understanding disease at an ever more fine-grained level. This is a set of lung cancer patients who have EGFR mutations, but have EGFR mutations which do not respond to any of the drugs that are currently available, which are highly active in that group. And this is saying we want to tackle the problem at an ever more precision-based mechanism and say this small subset of patients, which is quite large in the lung cancer population globally, how do you tackle this specific sort of set of patients? And this is a drug now which is in trial, in an international-based trial to treat just this subset of patients who have these sort of treatment resistance mutations in EGFR, led by the thoracic group. This is another example of pulling agents and doing innovative clinical trials and saying, how do we treat earlier and treat better? In the context of metastatic melanoma, pulling two inhibitors up front and actually probably going to change the paradigm for how you treat this particular subset of metastatic melanoma patients who were surgical candidates, and can you do a much better job of making that surgery much more effective and affecting sort of much more durable long-term responses by moving the drugs up front rather than after. And so this was a study led by Jen Warga and Rhoda Amario in the melanoma department. And last, to give you a sense of this ability to sort of develop drugs, this is an in-house drug that attacks the fundamental ability of cancer cells to generate their own energy. Again, sort of like Jen was talking about, cancer cells get themselves locked into decisions. What we have to understand is what that decision is and what blind alley that sends the cancer cell down, and then cut off the path behind them. And one of the things that some cancer cells do is they make a commitment to using batteries. And now you take away the batteries, now you shut off the electricity, and now the cancer cell can't grow anymore. And this particular drug was completely conceived in-house and is now in trial in patients in both leukemias and solid tumors at MD Anderson. Early days yet, we'll see if it works, but it gives you a sense of what you can do when you assemble these teams of people as we move forward. These are just 4 examples out of many. I could have cluttered the slide horribly with more and more examples, but I wanted to give you a sense of the impact that bringing research together with clinical and translational folks in a very team-oriented environment can actually have impact in relatively short time periods. Lastly, I want to tell you my thoughts on sort of where I think we need to go. You've heard talk about genomics, you've heard talk about data, and we want to extend profiling. We want to understand more and more about cancers, not at the level of generic classification, but actually as patients are treated. We want to understand what's happening in the tumors as they evolve. So we've embarked on much larger scale projects which are thinking about looking at tumors over time. If you treat, what happens? Where's that cancer going to go, and can you head it off at the pass? But I think more broadly, one of the things we're moving towards is trying to not get away from, but evolve our thinking in terms of what has been a very tumor-centric sort of view of treatment of cancer and move into a much more patient-centric view from the genomics perspective. It happens clinically, but we haven't really done it in a research perspective. If you look around the room right this minute, the one thing you'll notice that there's nobody sitting beside you or even on the other side of the room who looks just like you. And the reason they don't look just like you is because they're not just like you. They're different at the fundamental level of your DNA, slight differences, slight variations. We know some of that is detrimental. We can look at unfortunate families who have inherited mutations in BRCA1 and BRCA2, which have a higher risk of breast ovarian cancer. And that sort of world has gone on and been studied. We've done a lot on understanding the acquired events in terms of the TCGA, but we really haven't done much in bringing those two things together. Sort of the germline, if you will, what you got from mom and dad versus what's in the tumor, they've lived in sort of different countries and been studied by different groups of researchers. And that's been pragmatic and practical. We've done it that way because that was sort of the way it had to be done. And it's in it a bit sort of like the analogy I use. It's like two different countries with embassies. They get together for state dinners every now and then, and you know, they make speeches, but they don't really work together very much. There's no reason, technically or technologically or data-wise or computationally-wise, that has to continue to be that way. And one of the things we're really trying to think about at MD Anderson is how do you begin to change that and move into an era where you're taking into account variation from a very comprehensive standpoint? And how do you design studies that actually begin to understand the influence of your germline, what you bring to the table in terms of the variation you can see around you, that sort of glorious variation that is the human population, and where does that influence toxicity? Where does that influence the likelihood of short-term versus long-term toxicities, relapse, risk in terms of being able to tolerate certain drugs, risk in terms of more subtle risk of cancer risk in the population? How do we begin to put this together in a much more comprehensive fashion? And that's sort of, I think, the next place we're going to go. And so hopefully if you invite me back in a few years, give us a few years to get this thing going, we'll give you a much different picture and a much more comprehensive picture of at least the stuff that we worry about, which is variation and how that variation impacts not only the diagnosis, the treatment, but also the longer-term outcomes and quality of life in terms of patients. Because I think there's no reason we can't go after that problem now. It's hard, it's large numbers, it's expensive, but there's no reason we can't do this and do it well. And I think hopefully MD Anderson can help sort of push and lead the way in that space. So for that, I'll stop talking.
Thank you so much, Dr. Futreal. And now, back to my original instructions. Those of you who have questions, please raise your hands so that our volunteers can come and collect your questions. And then we will answer as many questions as we can given time, but I think we will have time. So we will open with a question for Dr. Litton. Is it possible, with the change in staging, could my stage in 2010 be a higher stage today?
Yeah, so it's always possible when we take into account the different biologies and some of the molecular testing, like the Oncotype DX and Mammoprint, where we, like Andy was just talking about, take into account some of the biology of the tumor itself, not what you inherited from mom and dad. And so that is all being used right now. And there are some patients who have a 1 centimeter tumor, but the underlying biology is very aggressive that would require chemotherapy. So we would see classically a stage 1 cancer, but I would treat like a stage 3 cancer and give the full, chemotherapy, a bit of the kitchen sink, I would say. And so we really have been doing this de facto in the clinic for a decade, but now we're actually calling it what it is with the new staging.
Thank you, Dr. Litton. Question perhaps for Dr. Sawaya, but this may be for all as well for Dr. Futreal. I learned that brain cancers are the only cancers that do not metastasize. Is MD Anderson studying why to apply this to other cancers?
Yeah, it's very interesting observation, and it is true. Primary brain tumors, those are cancers like glioblastoma I mentioned to you originates in the brain, they do not metastasize. It's exceedingly rare to see these tumors show up outside of the brain. It happens, but it's exceedingly rare. Why? We don't know. What we know from cancer metastasis, like breast that goes to the brain, melanoma goes to the brain, the environment where the cancer goes, like some breast cancer go to the bone. They tend not to go to the brain. Some go to the brain, not go to the bone. So there is something inherent to the cancer cells that make the environment inducive to their growth. That doesn't happen for glioblastoma. They just don't find the environment to grow outside the brain. In more specific terms, I don't know why.
A follow-up question for Dr. Sawaya. First of all, the audience member congratulates you on the presentation and says, does the term prevention enter the lexicon of neuro-oncology? In what way? And are there prevention studies?
Yeah, this is a huge, huge question. Again, our arms up in the air. The lung cancer can be frequently induced by nicotine and smoking, right? Melanoma, skin cancer from ultraviolet. Colon cancer is thought not only from mutation, but also from what we eat. There is no knowledge of what causes a primary brain tumor. No knowledge, no risk factor that we can identify. There are exceptions. Somebody that had radiation to the brain for something outside of the brain may develop brain cancer from the radiation, but that's less than 1% of all brain cancer may have something like that. There's no known. Is nothing you have done, nothing the patient has done, eaten, smoked, or whatever. Clearly, there must be an underlying genetic facilitation. P53 is a key player in cancer in general and has some role in brain tumors, but it's not. It's the minority. So we don't know why, and we don't know how to find it. As I mentioned in the animal model, we know the mutations that are occurring, or at least some of them that are causing brain tumors. But why are these mutations occurring? There's no environmental factor that we know of. Is it a virus? This has been floated around. So we don't know. Clearly, we're looking. One of our investigators has looked at several hundred families of familial brain tumors, which is rare in itself. It's less than 10% of brain tumors are run in family, meaning more than two members or more of a family have a brain tumor. That's rare, but there are enough of them over the years that we, or that person, Dr. Bondi in particular, has been looking not only at their tumors, but at their blood to see if there are genes that are being transmitted that we would say, if we have this mutation like the BRCA mutation, then this family has somewhat of a higher risk of a brain tumors. But to this day, we don't have an answer.
Thank you, Dr. Sawaya. A couple of questions that most likely are more appropriate for Dr. Futreal. Is there an identifiable or fundamental difference in the DNA of cancer patients as compared to that of people who never get cancer?
Not in the sort of the general population. I mean, what we know has been driven by, again, studies of familial clustering, that is, families which have cancer with multiple generations. So we know that the sort of the germline, if you will, what you get from mom and dad can hugely influence risk. There's been massive population studies which, will say there's variation in the population which can contribute on a population basis to risk. And we're talking about 1.1-fold, 1.2-fold, 1.3-fold. So in a population basis, you can measure if you have this bit of variation, your risk increases a little bit. For an individual, it's not particularly useful in terms of predicting risk. So what we have to get to is what is the interplay for that subset of people in the population that they carry this mildly increasing sort of risk, what are the factors that actually drive that towards development of cancer? I mean, is it interplay with the environment? Is it what you eat, what you do? Is it other things that we don't know about? So I think there's, in terms of the germline, there's very little, other than these high-risk syndromes, there's very little we can do to identify in that particular, on an individual patient basis. And I think that's the challenge. We can do huge population-based studies and describe risk. That's been done well. But translating that into your risk or my risk or her risk, I think is a much different proposition. And that's where I think we just need larger and larger data sets. I mean, it is a numbers game to a certain extent, but it's not just a numbers game about doing a bit of sequencing. We have to think about data. I mean, what much more accurate collection of all of your medical history, for instance. What has happened to you over a lifetime that may be influencing a downstream risk? And so we need to move away from this concept of sort of, we need to make medical records much more interoperable. I mean, I could get on another soapbox about all these things, but, we talk about big data, but at the end of the day, it's your data. And that's what we need to think about and move and collect your data in a much more efficient way so we can try to get at these things.
And a bit of a somewhat, not necessarily exactly the same question, but related to the research platform. Is there any research on immunotherapy related to pancreatic adenocarcinomas at this time? And are there any processes or any programs today to help prevent recurrence of pancreatic cancer?
I'll speak to, it's certainly not my area of expertise, but there are certainly, people are looking in, as with most tumor types, where can we leverage immunotherapy in an effective way in pancreatic cancer as well. So there are studies ongoing. And I think the results are still remain to be seen.
Right.
I mean, that's sort of the bottom line. I mean, it is being hammered on as probably as hard as it can possibly be.
So just to add on to that, I do think that the immunotherapy for a lot of tumors has been just really game-changing. For a lot of tumors, specifically things like melanoma and some of the lung cancer, some of the renal cancers. And what's fundamentally different about those tumors than we would see in, say, pancreatic or breast or subtypes of breast is that the immune cells are already sitting in those tumors, right? So all the drugs that you see on the commercials, so I have teenagers, a 12-year-old boy. So when I try to describe it to him, I was like, Harry Potter and puts on the cloak of invisibility and those drugs rip it off and all of a sudden the T cells start to eat the tumor. Well, if you don't have those immune cells sitting in your tumor, you could rip that cloak off all you want and nothing's going to happen to the tumor. So the idea that those single agents that are being used so successfully in melanoma would go across the board is not what we've seen. So tumors like pancreatic breast, some of the other ones that don't inherently have those T cells sitting in them, what I think the really exciting research is how do we kind of inject those tumor cells, whether it's we put combinations of both revving up the immune system and pulling it back. Do we inject something like a virus or a vaccine directly into the tumor, stimulate, use radiation? Now, all of these are being used in trials right now, and I'm very, very hopeful that we're going to find that balance of how to get these immunotherapies to work in the other tumor types.
Yeah, and just to chase that really briefly, I think this is a hugely important point about why we sort of build the things we build. A negative trial is a negative trial. But if we don't take the time to collect samples from that negative trial, we can't understand anything about why it didn't work. And so again, sort of back to Ray's first point about tissue collection, understanding the molecular biology from the tumor itself as it's being treated. And again, sort of these ideas about immune cells being in, around, or not there at all are being hugely informed by setting up the systems that have been set up at the institution to look, once you start treating, what happens? Did immune cells leave? Did they come in? So these are the things that I think we have to really think about. They're hugely important from the research side, which are directly partnering with the clinical trialists now to really understand the system in motion rather than sort of trying to guess it from something you did 6 months ago.
A couple of additional questions for Dr. Litton. What happens to stem cells, the tumor stem cells, after treatment of the HER2 positive malignancies?
You know, I think that's a really great question, and I might actually phone a friend to Andy next to me. But, you know, that is the key importance of why we're looking at biopsies, and we're asking patients who you know, I think have been very responsive to that, is not just one biopsy and one blood draw, but several. You know, we are seeing, in addition, what we're doing is taking those tumors and building kind of a mouse, kind of an avatar at the same time. And it's really intriguing, some of the things that we're seeing, like what are the tumors in that very heterogeneous group of tumor cells that die off, and then what regrows and becomes resistant. So I don't have that answer for you, but that is things that Andy is working very hard on, I think.
Yeah, I mean, we talk about the tumor as a monolithic entity, but quite frankly, it's a population of you know, subspecies who have slightly different flavors and slightly different characteristics, and you can think of it as a tree. There's branches to the tree, and different tumors will have really complicated, be oak trees, and some tumors more like palm trees. But eventually what you want to do is cut the damn thing off at the trunk.
Right.
And a lot of work is going in right now to understanding, you know, that architecture, because that architecture tells you where you may have to go to have to be the most effective in terms of eliminating, not just sort of tamping down. And I think that's, again, part and parcel of the research we're all trying to do, is understand the complexity of the system so that you can find the key point to poke it with a big sharp stick.
Thank you. That's a great metaphor. Sometimes we
Love
only
that.
kill the leaves and the tree just re-branches and reflourishes. Dr. Litton, an additional question is, what is the future of preventing progesterone and estrogen-prompted breast cancers from progressing to higher stages?
Sure. So in the prevention setting, we are using some of the standard anti-estrogen therapy for those patients who are at high risk of developing an ER-positive breast cancer. In patients who have already developed an ER-positive breast cancer, we have had several drugs that we've been using for decades and decades, tamoxifen, the aromatase inhibitors. But what we found, which I think was one of the biggest things we saw in ER-positive metastatic breast cancer, is that if we pair that anti-estrogen therapy with, again, it may not be the trunk, but it's pretty close to where is the CDK inhibitors, where we're seeing, I have patients, you know, right now still on the original trials with their disease completely controlled 5-6 years out. And that really, in my career so far, I haven't really seen that to that extent. So it's pretty exciting. And because we're seeing these combinations work so well in this setting, we've moved them to the early setting, both preoperatively as well as after your surgery, to see if we can bring that same synergy earlier on, cure more people earlier on, so that we don't have to treat them in the metastatic setting.
Thank you so much, Dr. Litton. And regrettably, I'm being informed that we have run out of time. There are only a few questions that we unfortunately could not get to, but if there are burning questions that you would like to address one-on-one personally to our presenters, I'm sure they will
just be
be
right out there.
happy to stay for a little while and respond to your questions. I want to thank you so much for you're such an attentive audience, and most importantly to our panel for their excellent presentations, very illuminating and encouraging news. Thank you so much.